Thanks. Well, it's a privilege to be here, and I want to thank this distinguished group and also the organizers, and also recognize those that may be joining us from online. In 1972 or thereabouts, the economist Anthony Downs noted, and I'll quote, what he called the issue attention cycle, and he remarked that American public attention rarely remains sharply focused on any one domestic issue for very long, even if it involves a continuing problem of crucial importance to society. And I think that we're at a unique point in time, really, with respect to both the opioid epidemic as well as the care of patients that have pain. And it's really one of opportunity to scrutinize the role of coverage and reimbursement policies and the role that they can play both in reducing the overuse of opioids and improving quality of care for those in pain. My comments are largely based on this study, which I understand was at least alluded to briefly yesterday, and this was a study of 50 Medicaid, Medicare Advantage, and commercial health plans. We were fortunate not only to have funding from the Department of Health and Human Services with support from NIH and CDC, but also the active collaboration and technical assistance of a variety of individuals, including Wilson Compton and Jamie Hayward, who I know are here, Linda Porter, who I believe has participated in this workshop as well. So let me briefly share 3 findings from this study. The first was that there was wide variation not only in the coverage of specific non-pharmacologic treatments, but also in the terms of coverage, even of those treatments that were covered. And it was this latter point that I thought was actually more interesting and unexpected. I wasn't naive enough to think that there would be uniform terms of coverage across things like physical therapy, but the variation in terms of the, with respect to things like the qualifying conditions, the number of visits, the duration limits of a single prescription, and expectations regarding improvement in functioning and recovery really were remarkable. And I eagerly await evidence such as may be coming down the line, but I also think that this variation raises important questions as to the value of model coverage policies. And as one congressman said, I think last year or so, referring to the opioid epidemic specifically, the cost of doing nothing is not nothing. So I think there's a real urgency and opportunity to improve the consensus regarding model coverage policies. Once again, not just with respect to what's covered, but the terms of coverage. The second finding has to do with the costs, and the point here is that there were large cost differences between the pharmacologic and non-pharmacologic treatments that we examined. So consider, for example, the median copay for a physical therapy visit among the 50 plans that we examined, among in-network commercial insurers was $30. If you think that a typical course of physical therapy is 6 to 12 visits, and compare that with the median cost of a 30-day supply of generic opioids. These are profound differences in cost, and you've got to believe that costs are one factor that influence ultimately the adoption of treatments in a choice set that providers and patients have in front of them. And the costs matter not just to patients, but here I'm including quotes that were taken verbatim from Medicaid directors in 2 states, one saying there's almost a fear factor among policymakers. They don't want to open up more benefits because it's almost always going to cost more. If my competitors don't do it, then we'll have adverse selection. Another saying the things we don't cover, we've never covered. To cover them would require a budget action. You know, with Medicaid expansion, we're a purpley state. We have a pretty strapped budget. It would be really hard to add a new benefit just based on the expense. So the point here is that that I think these questions of offsets and ROI or the like are really important, and I'm intrigued that there's been some different signals regarding the degree to which these treatments pay for themselves and how plans can best afford to cover them. The last finding that I'll mention is the absence of coordination between medical and pharmacy benefits. This was exceedingly rare. It was really the exception rather than the norm. Admittedly, administratively, this is very difficult to pull off. And here I've included one quote from a medical director about needing to outsource this from the plan perspective in order to do so. I think out of all the 50 plans we examined, there was only one, if I recall, that actually required patients to step through a non-pharmacologic treatment before initiating, for example, chronic extended release, long-acting opioids for non-cancer pain. So, one of the biggest myths about the epidemic, or that's driven the epidemic, is that there's somehow a conflict between reducing the overuse of opioids and improving quality of care for people with pain. And there's no conflict here. There's absolutely zero conflict. And so I think that strengthening and coverage and reimbursement, access and quality of non-pharmacologic treatments is a great place to start. Thank you very much.